because we have very similar model, but it's just that most of our PCPs are being paid on a fee-for-services model, then they don't want to lose their patients. So that's why it's hard to get them to refer their diabetic patients to our team.
So, and that's one of the reassuring parts of the program. These, the patients are seeing the clinical pharmacist, the clinical social worker. It's not like they're being referred out to another physician, and it's the team that's supporting the primary care physician to care for their own patients.
So did I hear you correctly when you said that that the grant sort of dried up and right now the team's running on 2 legs instead of 3? So I guess the question is, what doesn't make sense is you had excellent results, right? It's must be frustrating to your team members as owners of this initiative. If you have excellent results, was it not an economic, didn't it make financial sense anymore for this funding to continue because it saved the insurance companies the money and those patients ending up without their feet and in the hospital, etc. So do you want to just give us some your thoughts on that?
The program will continue. It'll be funded by Greater Newport Physicians, and so we took a 1-year grant and we made it last 2.5 years, and we're going to reassess. We're still collecting data from what happened when we split up with the Hoag staff in terms of the A1C, LDL, blood pressure control, eye exams, foot exams, all those things critically important, and we'll add on as we need to because we as an organization are just amazed at our results, and we don't want to lose the program.
Great. Thank you so much.
Thank you.
Great. In the interest of moving forward with the agenda, I'm going to ask that the Kaiser group, Drs. Cantor, Bogany, and Duddle also join us here at the front. We're heading into exciting territory. We saw a great example of a breakthrough improvement in a network physician organization, and we'll continue with breakthrough stories. The next 2 sets of presenters are from delivery systems that have achieved really excellent performance and breakthrough improvement through persistent, continuous quality improvement. First, we're going to start with the Palo Alto Medical Foundation, Dr. Edward Yu, who's the medical director for quality at the Palo Alto Medical Foundation. And he's going to discuss the long-term integrated strategy for building excellence.
Thank you very much, everyone. Delighted to represent my organization to be here. On a personal note, I trained at UCLA, and I was an attending physician at Kaiser Woodland Hills, so a seat of front tables here reminds me back in the days when I was in Southern California. Anyways, next slide, please. Or am I supposed to do that? Oh, okay, self-service here, got it, okay. Okay, the obligatory who we are slide. When I do this, I always go back to my analysts and get the updated data, and I was kind of sometimes surprised myself. I was physician 137 at the foundation, so now we are over 10 times the size, over about 1 million patients. That's our geography, 35 plus locations, 46 clinical departments, and our payer mixes as follows. So we, like I think a lot of you here, live in this mixed reimbursement environment, and obviously the incentives are not always aligned with depending where your patient populations are, and our journey about delivering a care delivery system that matches all the alignments have their challenges, and love to share some of your learnings and your experiences, and I'll tell you a little bit about our journey as well. Next one. Okay, for those of you who are in the quality metrics world, the last few weeks has been very exciting. You know, we got our G-Pro results, we got our IHA P4P results, and we got our OPA results. And I'm proud to let you know that our organization have done stellar for all of them, and a testament to the teamwork and the leadership that we have over there. And I'll come back to the slide a little bit at the end of it. So, for those of you that don't know a little bit about me, I used to be a published film critic, so I love to tell things visually. So my portion of the talk as we go forward is going to be more qualitative rather than the quantitative part, which we've heard a lot about. So I'm here to kind of engage your mind and also pay attention, because there are 4 questions that I'm going to ask you, and hopefully I'll embed all the answers in my story, so pay attention, follow me along, and hopefully glean some of our strategies and our tactics that we used to achieve the results that we did. So, we begin. Names have been changed. I am a family physician. I continue to see patients, and this is actually one of my patients, but I changed his name. And he actually looks like that, except without the mustache. Jesus Gomez. He has an email address, jesusgironchef@yahoo.com. So he really wants to be an Iron Chef. 5 years ago, comes into my office, new to me, and for a check. And in our system, we prepackage the patient ahead of time, so we usually get the test ahead of time. So we got them, A1C, double digits came in. I said, "Hey, Jesus, nice to meet you. I understand that you want to be a chef." I said, "Yeah, I am right now a chef, kind of line chef at the local country club. They're working my way up." I said, "I see your medicines that you take, oral medicines and insulin as well, but your A1C is above, are not at target." I said, "What's going on?" "Oh," he said, "well, I don't take those medicines anymore." I said, "How come?" "Well, you know, doc, I take the medicines, but I get side effects because I think my blood sugar goes too low. Because, you know, in my line of work, I don't eat regularly, so sometimes I don't eat and I had to taste food, and it just doesn't work for me, so I decide not to take it at all." I said, "Well, you know, that doesn't work quite well." I was thinking in the back of my head, you know, he's on my diabetic registries, we have these transparent quality metrics performance, and I, at that time, was Associate Medical Director of Quality. I said, I can't have him screw up my scores and my ranking. So I said, "Well, Jesus, let's put it this way. Don't you think it's important for you to go against Bobby Flay on Iron Chef America," which I actually watch with my family a lot. And he said, "Yeah. Well, to do so, don't you think it's important that you are able to walk in that stadium with both of your legs so you can compete?" I said, "Yeah. And do you know that the people in that show, that you see some of those chefs that sweat a lot and it seems like they're going to die in there? Well, that's going to be you if you don't control your conditions better." So then we kind of talk about it. So, well, given that you don't eat regularly and randomly, let's just put you on keep you on the long-acting insulin, and we'll put you on short-acting insulin as needed, get rid of oral medicines and see how that would work. Then I said, okay, we tried it, and along goes along his way. So we'll check A1C in 3 months. 3 months went by. Send an email, a reminder. Didn't happen. 6 months later. And at that time, they escalate. So there is a letter that goes out to him, an email. It hasn't heard back on that. Then my podiatrist pings me and said, "Hey, Ed." I said, "What's up? What's going on, Lou? You know your patient, Jesus Gomez, that wants to be an Iron Chef?" "Yeah, I know him." "Yeah, I saw your note." Turns out he had a cut on his foot, got infected, and long and short of it, had a foot ulcer as related to that. Had to be hospitalized, saw podiatry, kind of clean it up, and kind of my specialist kind of connected him back to him, and then sure enough, he came into my office. So I said, "Hey, Jesus, how are you doing?" I said, "Oh, I'm doing better now. I noticed that you haven't seen you for a little while. What goes?" "Wow, doc, you have to be very proud of me." I said, "What happened?" "They promoted me to become executive chef at the country club." I said, "Oh, great, fantastic. Then how come, did you get our reminders?" He said, "Yeah, but what happened?" "Well, I'm too busy now because now my roles are bigger. I work weekends, I work evenings. It's wedding time, so I got to be busy and blah, 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 blah." So obviously he had barriers to get his care, and it took him to land in the hospital for those few days to get him to come back to see us. So I said, "Well, for you, well, you know, we have weekend clinic, we have evening clinic. But doc, that's the time that I work." I said, "How about in the morning?" "Well, it doesn't really work for me. Sometimes I have to talk with my team, get the menu together. That's when it happens. It's just hard for me." How about your day off? I mean, on a weekday, does it work? Well, I got family things, so life gets in the way, right? We heard that a lot. Then it dawned upon me that this patient needs something different. So, well, I said, Jesus, how about this? We have a clinical pharmacist program that can help adjust things for you, that can work with you through the phone. How would that work? So, okay, I'll try it. Okay, then we hooked him up with our clinical pharmacist that kind of telephonic management according to our protocol, worked and just with him, and as we go along, and initially things worked well. 3 months came by, waiting for the A1C, didn't come in. Then a few months later came by, didn't. By this time, it's about Thanksgiving time. As you know, in quality metrics, the closing period for these things are at the end of the year. I said, MA, call my patient. Keep calling him every week until he gets there. No response. Then I said, I need to call him. Called him. Didn't get a hold of him. I said, Jesus, hey, what's going on? Haven't heard from you a little bit. We kind of lost touch with you. My clinical pharmacist said you haven't returning the call. But, you know, it's really important for us to know where you are. I know you're busy right now. The best thing that you can do for you is that for us, kind of see where you are, if you can. Got everything ordered for you. We got your lipid panel. Back in that time, we're still in the old guidelines. That you can come in non-fasting and just come in and get it done. And you know, the best Christmas gift you can give to you and to me is that for you to come in and get it done before Christmas so I can know where we are in the back of it, just to get that patient, check for that process measure. And lo and behold, I was working near Christmas Eve that day, and sure enough, that day I got the result from him. So he came in on Christmas Eve, probably before he went into work that day for a clinic, got it done. And he did show improvement in his A1C. Not quite at goal yet, but he did show improvement over there. So I was very happy about that. So we're very happy for him. He still continues to move along. However, I noticed the following year he kind of dropped off of my patient panel. So what happened is that I think he got another job out of the state as he moved on, probably on his way to his becoming Iron Chef. But as you know, some of our patients that come back to our area, so we'll just see where he is. Anyway, so that's the story of Jesus. Question number 1. This goes back to a little bit what we do in our system. So all this just, what are the outreach processes and reminders that we do not deploy at PAMF? Okay, no. You got to tell me how this works. I have no idea. I can see there are fewer people in the room because some of them left because I don't see getting up to 70, but this is good enough. We can move along. How do we get the results? Okay, you're right. Number B. We have automated phone calls for appointment reminders. When it comes to clinical work, we do not deploy that, and it's all either using technology we mentioned, or it is the system involves triage and tiering to calling the patients. Because as you know, for those of you doing the work, particular clinical things, when you talk to the patient, often there are additional questions that they may have, and we felt that it's important that we reach them to capture that and to bundle additional things that may happen over there. So multimodal outreach processes that we have at PAMF. Okay, next question. Didn't really touch upon all of them, but I think this is pretty intuitive. Give you a hint. We're kind of like what the Greater Newport physicians did. Go on with the answer. I'm pretty sure you'll get them right. Oh, wow. I'm very impressed. Yeah, so we have our version of building a healthcare team, which I'll talk a little bit later, and just very mirroring the stories you just heard earlier from their previous presenter. Oh, okay, this is what the slide is. So building a care team. Now, this is an older slide that we put together. As you can see, different roles on that. However, I want to link this with the next thing I want to talk about. Tools and technology. What tools and technology are not currently deployed at PAMF for chronic care? Let's see if anybody, just venture a guess and see. Okay, I think that's good enough. We'll take a look and see. Pretty close. C, telemedicine. This is one of the reimbursement issues that we face in our world that's putting a slow process on that. At present, we do not deploy telemedicine for chronic care visits yet, although I am pushing for that, and I think that will eventually happen. And we have all the other elements like a lot of the groups over here do. And I think the trick is, how do we leverage these tools and technology that work for that particular patient? Although my geography is Silicon Valley, but not every my patient has an email address, and not every my patient has an iPhone, and not every my patient wants to touch the internet, particularly after all those security breaches we've been hearing. So the trick is, how do you know what the patient needs at what time, with what, or who? And a lot of our design elements and our thinking is built around understanding what the patient needs is and developing all that. Just a little other visual about a plethora of activity in my 1,500 physician group practice. And for those who've been to other forums, you may have heard a lot of the other stories over here. But and the reason I show this is that, I don't really know what the magic bullet is. And if anybody in this room knows, please tell me, and I'll be happy to bring it back to my system to do. The technologies and the staffing that we have, it's not uniform at PAMF yet. Part of our advantage is that we have different experiments going on in different regions. Some are more tech heavy, some are more staff heavy, and we have systems to monitor to see what does work and what doesn't, and try to spread it across over there. And I think part of it is coming to forums like here to share, to learn, to see what seems to work, and would it be adaptable to your patients and your geography with your patient mix. That is what the key is over here. So this is my favorite question, because I feel part of our secret sauce at PAMF is embedded in the answer to this question. And this one in particular, I'd like to see as many of you guys to vote, because I think your answer will be reflective about your values, what your organizational values are, and I'm very curious if it matches with what our foundational improvement efforts and strategy and design elements in our thinkings are. Okay, let's see the answer. Very good. The answer is A, definitely. I started with a patient story, and we have lean deployment in our organization right now about patient value. But our work in this arena started before then when we do so, and realize that you cannot do this, and you will not be successful unless you truly understand the patient need. And each patient is different, and understand that when they come to us in our bricks and mortar, the issues that we can solve are only about 20% of them are clinical in nature. The other 80% is how they live their life and the challenge that they have. And the better we understand that and see and understand what our role is in the patient's world, the better off we are. So we talk about this, and to have the patient say, let us know me as a patient and meet me where I am. Today, I may do well, but the next day, I may have a crisis where I lost my job, or a significant family member died, and I can't take care of myself anymore. And the resources and the needs that I need as a patient will differ. And that continuum continually changes, and we need to have a healthcare system that has the capability and has the flexibility to put together and understand where patients are and assemble the care team and the resources they need so that they can be successful. Because ultimately, for chronic conditions, it's really about how they live their life and how they live with it that determines success. This is way back in the early stages of our design event. I still pull up because I think it's very relevant, and to me, this is articulating continued challenges that we have at PAMF in our geography, in our payer mix, and how we go forward, is that there are significant challenges in our mindset that, oh, we had to cure disease, we had to take care of them when we see them face-to-face contacts. And we know that that needs to change. We need to meet the patients where they are and shift the thing that our goal is really keep them healthy and to keep them happy and drive value for the system overall. Transforming teams so that it's not the doctor that has to do it all, it's how their care team is and what that mix is in a way that is economical and efficient and meets the patient needs, and how to weave in technology into it. And finally, the piece that I think all of us and that I feel that we need to do more about is how do we align incentives in a whole healthcare system from the payer side and all that, so that we can really move together and that we are incentivizing the right thing for the whole system. So in close, part of my mission of taking on the job that I have is really to really achieve better outcomes and to build upon the success that we have, the rewards, so that we can continue to push and be recognized as a top performer in quality metrics across not only in the state but also in the nation, and to really challenge us and our system that even though in some things we are considered excellent, but where we are right now is nowhere near where we need to be, because our obligation is really to our patients and the populations that we serve, and we need to continue to innovate and continue to push us hard, develop strategy and tactics, and align things together so that people like Jesus, wherever he may be, will have a trusted care team member to help with him to make the right decisions and get him in goal, so that the high-cost items in that top end of the triangle that we've seen in earlier talks does not happen, because it is based on that we can keep our country relevant, because the alternative is dire, and all of us in a room will have a role to play so that we can keep us relevant and healthy. So on that note, I'm done. Thank you.
Thanks, Dr. Yu. Do we have one question for Dr. Yu? We can
I
entertain.
believe I gave you some time back.
Oh, you did.
Just wondering, I heard you say you have the 15, oh, thank you, Michael. You have 1,500 physicians, then how many patients coming through your doors, give or take, Mr. Gomez?
We have 970,000 active patients in our whole geography.
Okay, thank you.
Not all of them come here for primary care services, but a good majority does.
We can probably take another question from the audience if anybody.
That one was easy.
Clarifying question. Thank you, Dr.
Thank you.
Thanks. Next, I'm very excited to present our wonderful trio here of Kaiser Permanente physicians. Dr. Michael Cantor is Regional Medical Director of Quality and Clinical Analysis at Southern California Kaiser Permanente Medical Group. We also have Ray Bogany here, Physician Director of Complete Care Management for Kaiser San Diego, as well as Dr. Jim Duddle, who's the Diabetes Care Lead of the Care Management Institute and Community Benefits for Kaiser Permanente. Even within a large integrated system, there is room for additional improvement, and we're going to hear the story of Kaiser's systematic quality improvement approach and San Diego's turnaround.
Okay, it's great to be here. Just for running a little, I'm amazed actually that people they still seem awake, and this is a really good conference. I was just reminiscing, I went to the first one of these, and everybody was like fighting with each other, and I'm thinking, oh my God, this is never going to go anywhere at all, but this is really pretty incredible. I think it's a tribute to those who have been slaving away for the last many years on this. So do I get a thingy here? Yes. What I'm going to do is talk about a different model of care that we've termed complete care, explain how that works. It's a system of care, and then explain how that was transferred in our San Diego facility and really had some outstanding results. So I'm starting with a question here, and go and answer this. And I'm noticing the response rate is going down as the day goes on. We're not quite as snappy as we were in the morning on this thing. So I'm going to think maybe 40 is a good sample size. All right, we can cut that off. All right, so everybody's getting it right. And the reason that E, all of the above, is the correct answer is because I said so. But no, it is the correct answer, and I'm going to explain why as you look through our model. But there's no one magic bullet that actually can drive a system to top performance. So we have what we call complete care. It really refers to taking care of every patient in every place. They don't have to be in primary care. They don't even have to be in our facilities. We take care of them wherever they go, every time, every visit, and that's the underlying philosophy. If you want to learn more, we published our model in the Joint Commission Journal on Patient Safety and Quality, and I could spend about 4 hours talking about this, but I don't have maybe 4 minutes. So there's a sort of paradigm shift in my thinking a while back, which is if you actually look at disease management, even if it's prevention, there's certain functions you do, and it actually doesn't matter what disease you're talking about. And so if you look at the vertical lines, there are various disease programs, and I used to be driving myself nuts trying to keep track of them all. And then I realized we kind of do the same thing for every disease. So if you start looking at the bottom, pretty much anything you manage is going to need some practice guidelines, some algorithms, and perhaps some physician education. Most things are going to need clinical information systems, which deal with not only alerts in our electronic system, but registries, data feedback to doctors on their own performance, that sort of thing. We have a safety net function, which I won't talk about too much, other than we monitor for errors in care. We've actually seen a drop in our rate of rhabdomyolysis by preventing dangerous statin combinations from continuing in patients. I'm not going to go through all of these. Our outreach I'll talk about later, but any disease you can use outreach techniques. Proactive encounter refers to a model of care where when you walk into our offices, there's an electronic checklist that tells the physician all of the care gaps that that patient has. Not that much different than the checklists used by the surgeons in the OR. A separate checklist for specialists, so nobody is exempt from this kind of model. And it works well. Health education, people have talked about, it's key. We have our own separate department with several 100,000 patients per year attending education programs. And so if you do all this stuff, you just plug in any disease, all that changes is the details of that disease. The meds are different, the treatment may be different, but the infrastructure and management approach is the exact same. So build your structure, and then you can have a whole bunch of these things. And managing cardiovascular disease is not any different than managing colon cancer, according to this model. So how does this model work? We actually showed, if you look at HEDIS measures that went between 2004 and 2012, there's actually only 25 commercial ones that stayed intact that we could trend that long. Our improvement was around 13% for both commercial and Medicare, and median for the rest of the country was about half of that, maybe a third of that. So the model has allowed us to accelerate our rate of improvement on a wide variety of HEDIS metrics over a long period of time. Here's a question. If you wanted to save as many lives as possible, which two measurements would you work on? So let's go. And I'm not seeing any. This is a tough question here. There we go. And then you'll see the answer in a minute. That's a good enough response rate. So we got A1C and hypertension. The correct answer, and this is going to be based on Kaiser data, so I'm going to put the caveat, it might be different for yours, is actually B. And we'll go to this slide here. What we started to do is measure our rate of improvement since 2004. And part of the reason why blood pressure and colon cancer come to the top is we've been able to get roughly a 40% jump in the rates. So if you were starting out much differently. Maybe this would look different in your care institute. The reason I have this slide, these lives saved are actually projections. My methodology is horrible on this and would never get into any medical journal. But I've never been questioned. I show this to our doctors. 6,000 physicians have seen this and not one question about it. And the reason is it's really to illustrate the impact. When you're trying to motivate physicians and you come in and you say, gee, the A1C control rate went up 1% in the last quarter, you feel like the Fed chairman talking about interest rates going up, and they just go to sleep. So this has been highly motivative, particularly for specialty physicians that may not be so interested in diabetes or blood pressure, for staff where they don't have the medical education. So we're up to about 18,000 lives with just these measures here. So how does complete care look like? It is proactive, it's completely team-based, focuses on the person. We call them persons, not patients, not just the presenting symptom. It goes throughout the care continuum and addresses all of the health needs. Like I said, checklists come out for people that actually know what to do. So testing for A1C is important. If you look at patients who access medical care who need a A1C level, they haven't had one in a year, what percent go to primary care versus specialty care? And let's go. So we're 40% is a good enough response rate. I'm not worried about non-responder bias here. And it looks like most people think it is D, which is 75% of patients needing the test show up in primary care. So the answer is 60% are in specialty care, 40% in primary care. Why is this important? If you're playing baseball and you got 9 players on the outfield and you don't involve your specialists, it's like going out there with 4 or 5 guys on the field and trying to play. Not a good sight here. So we monitor our specialists and they have to perform on filling some basic care needs, and they're happy to do it. When you look at hypertension, one of the things that's been had less attention is actually identifying hypertensive patients. You could have the greatest control rates on the planet, but if you don't identify them all, you're not doing a good job, and you certainly have a huge opportunity to prevent disease. 18% of our hypertensive patients are identified in specialty clinics, not primary care. This is done on a retrospective study over about 2 years. Interestingly, 14% of patients who show up with blood pressures over 180 show up in specialty clinics. Optometry is big, neurology is big for this, dermatology. So involve the specialists. What is the next question here? You've got effective approaches for patient activation. Let's start going here. What are they? And we can stop. And these are easy. Everybody knows you got to say all of the above. So I'm going to talk about just a few of these because I can't talk about them all because they'll kick me off here. Regional outreach, we've centralized all our outreach efforts. We used to have 1 billion people sending out letters to patients. Everyone had a learning curve. Now it's very standardized and slick. 8 million touches a year. When there's forest fires in the LA area, we can send out an outreach to be careful on the air quality within about 10 hours. Very cool stuff. It engages people when they know what they're supposed to do. We have, our portal system, online portal. This is huge for patients. They can go on there. They can look at a large portion of their medical record. We have something called the Personal Action Plan. People can go in there and look at their care gaps. So if you've got diabetes,